Greg has worked in this area, but I'll let him tell his own story. But tonight he's talking to us on understanding male sexual health and well-being, and he's got some very interesting angles and points to make to us, and I'm sure the questions will be forthcoming. And what Greg has also done as far as PCFA is concerned is contributed greatly to us getting a better understanding for gay and bisexual men, and we now have, with his help, 3 support groups up and running, not in any order, but Brisbane, Sydney and Melbourne. He's been over in Adelaide working for us. We're working in Perth, and the next areas, well, you've been in Adelaide just recently, and the next areas are Darwin and Hobart. So we're really moving around, and Greg helps us tremendously in this area. So without any further ado, Greg, you've got the floor.
Great. Well, thanks everyone for coming along tonight on this cold, blistery night. I'll introduce myself first. I work as a men's health consultant. I live in Newcastle, but I work across Australia and overseas. And I've worked for myself for the last 10 or 12 years. The things that I do, I run professional training programs for healthcare workers, community workers, people in the human services sector on how to more effectively work with men. Because part of the reason why men's health in Australia is so bad is because we don't engage with men very well. And our systems aren't always very men-friendly at all. So I do a lot of that, and at any given time I can also be engaged in running programs for men out in the community, or event management services around men's health, or project and research work. And part of that project work, the work I do for PCFA, would come under that area. So I'm a health social worker, have been for 32 years, and I've worked in the men's health area for 22 years. There's a state peak body for improving men's health and well-being and relationships in New South Wales called the Men's Health Forum of New South Wales, and I'm the president of that. There's 5 of our states in Australia have peak bodies for men's health, and they all operate differently. New South Wales is the only peak body in Australia that's committed to actually running men's education and health promotion programs within New South Wales, and the only peak body where One Health issue's actually been mentioned in our objectives, and that is to do health promotion around cancer. Okay, so we've put that in. The others don't have that, they don't go into issues, but we decided that the amount of men in this country with cancer was worth acknowledging that, now one of our objectives, so we always keep that in mind in what we do. There's also a national body, AMHF, which organises the National Men's Health Conferences across Australia every 2 years, and I'm on the executive of that. And I do some academic work at the University of at the University of Newcastle, and I'm the author of that book, Men's Health and Wellbeing, an A to Z Guide. Now, some of my past work has been in the sexual health area. I was the education officer for the Australasian College of Sexual Health Physicians. They train doctors to become specialist sexual health physicians. That's how it works in Australia. We're very lucky to have specialist doctors in that field. And while I was there, I also voluntarily was a sexual health counsellor at Sydney Sexual Health for a number of years, and I was president of the Sexual Health Society. I'm letting you know all this so that you know that I haven't just wandered in off the street and decided to talk to you about sex tonight, that I actually, that I actually might know something about it. What I wanted to start off with talking about tonight is some rather recent research that Eli Lilly did not long ago, 2012. We don't have a lot of sexual health research in Australia, so when something new pops up, we like to include it in our thinking. Now, this is an interesting one. The majority of men, 86% aged 40 to 69, consulted a doctor in the past 12 months with an average of 4 visits each. So again, that works a bit against that myth that's out there in the community that men aren't concerned about their health. They are. They are concerned about their health and well-being, and I think we're seeing a lot of generational change around that. Younger men are far more interested in their 20s and 30s and maybe into their 40s. So we're seeing that happen. But what were the symptoms that were most likely to prompt middle-aged men to visit the doctor were that it might be a sign, whatever it was, of a more serious condition, 73%. It was an everyday nuisance. It caused them stress or anxiety, or it necessitated taking time off work. All of that's pretty reasonable to me. They're the reasons that people go to the doctor, that men go to the doctor. However, sensitive issues, and by sensitive issues, we could imagine anything that goes wrong with our sexual apparatus, sexual erectile dysfunction, continency problems, anything like that, might be a sensitive issue for men. And when it came to that, 70% of married men talked to their partners. More than 50% of all men aged 40 to 69 felt uncomfortable seeking advice from the doctor about erectile problems or libido, which is interesting. 50% of men who experienced urinary problems had never consulted a doctor about that. So as we get into these more sensitive areas around men's sexual health and well-being, it paints a little bit of a different story. But this is also interesting. Self-esteem, looks and sex appeal remain important. This group, again, 76% of that age group, had undertaken some kind of health or well-being related activity. And when asked why they did it, 87% were health concerns. However, 29% were self-esteem, 28% to look and feel younger, and is that 11%? I think it's 11% to retain their sex appeal. Okay? So it's just not all about health. And I think this is painting a picture of, you know, men as we move through life, we like to be attractive, we like to look good, and we like to think that we're a functioning sexual person. That's really important to us. But those sensitive issues remained on the back boiler. 50% of men who experienced urinary problems had never consulted a doctor about it. Let's go to another look at this, another piece of research that's a few years old now, and it's looking at men and women and gender differences. And the first is lack of interest in sex. Women develop a lack of interest in sex earlier than men do and in larger numbers, and I probably need to explain that. As couples form and they form into relationships and they get married and they stay together for a long time, we see less sexualising and more socialising. That's what happens. They do have less sex. They're still very intimate with each other. They still have a great relationship. Their friends are just more important. Okay? In our 20s, sex is really important. How many hits we have on Facebook is majorly important. But as we get on a bit in life, other things become important to us. And often women will lose that interest in sex before men do. Unable to come to orgasm, again, the figure for women's higher in that area. Not pleasurable sex is higher for women. Worry about attractiveness during sex is pretty equal. Oh, no, actually it's not. Women do worry more, than men do on that. Coming to orgasm too quickly, which we'll briefly touch on tonight. Again, that's a big problem for men. Anxiety about sexual performance, actually fairly equal, a little bit, 1%, but markedly a little bit higher for men. And trouble keeping erections, obviously, is a problem just for men. What's sexuality? Just very briefly, that's a definition of sexuality, but sexuality is how the qualities that allow us to feel comfortable in our own bodies and to form relationships with someone else. It's part of our life before we're born until we die, but it can change throughout life. And sexual orientation, behaviour and identity are three very different and tricky things sometimes. Sexual orientation is who you're attracted to. If you're attracted to women or men or both or none. There are some people who don't have sex, by the way. They're called asexual, and they're about 0.3 something of the population. And guess what? We don't actually worry about them. They're happy that way, and they're fine. So we kind of leave that little group alone most of the time. If they're happy that way and there isn't a problem, that's fine. Sexual behaviour, though, is your sexual contacts and practices with others, the type of sex that you have with other people. And sexual identity is how you self-identify as heterosexual or straight, homosexual or gay, bisexual, who I used to say having a bet each way. Okay, bisexual, asexual, or why I've got whatever in there is that young people these days don't actually want to be defined by any of those terms at all. If they're asked about their sexuality, they say, oh, whatever, which is a really good answer, I think. I have sex, it doesn't matter, it's actually none of your business. That's what's, and the new generations that are coming up don't want to be categorised into those things. They want to remain a little bit fluid in their response and what they do. But the thing in here that's important is sexual identity and behaviour are not always the same thing. Let's look at some of the issues that come up for men. Sexual performance issues. I think there's a lot of pressure on men to perform fantastically good at having sex every time they have it. And there's an expectation that that's going to happen. And I can tell you it's not. Okay? But I think there's a lot of pressure on us to do that. There's a greater pressure, I think, on men than women to perform sexually. And as I've said, women can fake an orgasm, but men can't actually fake an erection. It's kind of visible. Okay? So there are some differences there. Common male problems are low sexual desire, erectile dysfunction, premature ejaculation, and the very premature ejaculation is coming to orgasm too quickly for a person's judgment. Retarded ejaculation is quite rare. That's taking a long time when you're having sex to actually ejaculate far too long. That's very rare. But both of those can be easily fixed. Not only are male difficulties more obvious and more likely to make penetrative intercourse impossible, but there's a greater social expectation, I think, on male sexual competence, which is what I was hinting at. Sometimes even female sexual function problems can be wrongly perceived or diagnosed as a failure on the male partner until we accurately diagnose that there's something wrong with the woman's functioning. That can happen quite a lot. It's a bit like the default position, oh, it must be his fault or his problem, when it's actually not. Intercourse difficulties clearly relate to men's problems in a way that he could feel inferior, guilty or inadequate. And his partner may respond with belittling comments, anger or feelings of being sexually unattractive and so on, which just makes the problem worse. The plain truth of the matter is that most men will fizz once or more in their sexual lives. When I talk to men about this, you know, it's not hard for them to understand if they've had too many beers in a night and they want to have sex with someone, it sometimes goes wrong. They get that. They really do understand that. They really do understand that basic connection with too much alcohol. But there's other reasons that that can happen as well. And men can feel traumatised by the event and worry about a reoccurrence, particularly with erectile dysfunction if it's psychological. If something goes wrong one time, they'll go into a situation, worry about it happening again, and while they're worrying, it will happen again. It's sort of like a vicious cycle. And anxiety and tension can make it less likely that you'll get a functional erection. Just on that, it's really unromantic and very mechanical. How we have sex is like we need to have desire. That's really important. We need to have some situation where we're desiring to have sex, then we need to engage in sex, and then we need to keep our mind on the job. While we're having sex and we think, oh, what am I going to have for lunch today? The erection goes. Or what time was I supposed to do? Oh, gone. The minute this brain up here doesn't focus on what it's supposed to do during the act of sex, you'll lose an erection. But what normally happens in there is anxiety or tension come into the brain. Other triggers for sexual performance issues could be differences in preferred activities and sexual priorities between two people. The situation, this is for newly married couples, lack of privacy when children arrive. It becomes far more difficult to have sex. You know, where do you find the time and the place when you've got kids around? Guilt about infidelity, trying to impress a new partner, overuse of drug and alcohol, and the effects of a wide range of medications. So what I was saying was anxiety and arousal, the two A's don't mix. You've got to have arousal on its own. You've got to keep focused on what you're doing and not let other thoughts enter your head and be more relaxed. Other triggers to sexual performance issues could be anxiety about previous failures. This is the vicious cycle I was talking about. A partner who's not attractive to you, A moody, cross-irritable, tense or preoccupied partner, a passive, unenthusiastic or unwilling partner, poor communication skills within the relationship, and differences in sexual desire, drive and other differences between partners. Of course, all these issues are pertinent to people in relationships. Bear in mind, 39% of the male population in our country over 18 are single. 39%, okay? So a lot of these things refer to long-term partners and things that can happen to long-term partners. Differences in sexual desire. When two people come together and decide to form a relationship, it's extremely rare, totally rare, that they both like sex 3 times a week. Someone will like sex twice a week and someone will like it twice a month. They need to work that out. And most times they can. But if it becomes a real problem, it's called sexual discrepancy, and it can require some counselling to work that out. The foundations of a fulfilling relationship should be pretty obvious to us: friendship, good communication, a good sex life, trust, and shared values and interests and hobbies. Chronic problems in relationships, when they come up, I won't spend too much time on this. Sexual incompatibility or some dysfunction can cause problems, of course. Diminishment of passion, issues around monogamy, family and outside interests, serious illness, unemployment, poverty and parenting all affect what's going on in the bedroom in the relationship. Oh, and sexuality changes. Differences in libidos can be a problem for a lot of couples, but they can sort that out. There were a few tips in there on how to do that. This is talking about if you've got difficulty initiating sex, and often couples do. One doesn't want to do it or the other one doesn't want to do it and they think that there's something wrong. We need to actually talk and initiate sex and tell your partner what you need and speak out about what you want, saying I statements. I think my body responds better when this happens, and talk to your partner about this. Chronic relationship problems. Now, this is a bit tricky. Sometimes there can be problems in the relationship and they get acted out in the bedroom. Or there's problems in the bedroom and they get acted out in the relationship. Right? So we need some expert counselling in here to work out where's the bulk of the problem. Is it happening in the relationship or in the bedroom? Or a little bit of both. But it takes a good counsellor and a sexual health counsellor to figure that out. But again, it's about good communication. As we grow older, it's about the intimacy needs versus sexual needs as we get older. Also, other things that can affect sexual desire are stress, expectations. With single men, expectations with a new partner causes a great deal of stress. Worries, anxieties or lack of time, availability and difficulties in meeting people. Lack of sexual desire can be all of these things. It can also be the way we feel about ourselves, because our bodies change throughout life and they can change naturally, of course, through ageing, but then also through injury or illness or accidents. And we can have negative thoughts about ourselves and what we look like. And that can possibly lead to a sexual function problem or performance anxiety. Best to check that out with a counsellor or talk to someone about it. This is kind of interesting because what I'm going to take you through now is what normally happens to males as they age. No cancer in place, no illness in place, no prostate cancer happening. What I'm going to show you next is what normally happens. And I think this is interesting because you can see what normally happens and then you have some understanding of what can happen when you have an illness like prostate cancer, okay? As we get older, and I'm talking about 60 and over, more prolonged and intense stimulation is required to keep an erection for longer. You know when you were 18 and you got overexcited on the bus? Well, you're 60 now, you don't get overexcited on the bus anymore. Don't go on, but you don't. That's true, maybe that's why we don't. We don't go on buses anymore. The testicles may become smaller. Actually, they do reduce a bit in size and more flaccid, but it doesn't affect your performance or what happens or their role. It may take you longer to get an erection, and erections may not be as firm as they once were, but they're just as useful. The refractory period's the time between ejaculating and coming and getting hard again with another erection. And that increases sometimes up to 24 hours as we get older. But there are other ways of getting and giving sexual pleasure. When we were 18, the refractory time could be 10 minutes. It probably was, and we change over time. May take you longer to ejaculate, and I've got to put in there, so what's the problem? If you're enjoying what you're doing, well, what is the problem there? Some older men won't ejaculate every time they have sex, but this means that they don't have to go through the refractory period and they can have more frequent erections. So far, this is reasonably good news, okay? It's looking pretty good so far.
He smiles a bit.
Yeah? Your ejaculation is less powerful and orgasm's less intense, but the sensations are just as pleasurable. It's just a little bit different. And I've also known from running a sport group with men who've had prostate cancer or had the prostate removed, they also say that orgasms are different. Some have actually said they're more intense, but sometimes they say they're just a little bit different. Sexual urge can come less frequently, but this is not related to age, rather than a concept out there in the community that as you get older, you don't have sex, you know? Older people don't have sex. The idea that young people have of their parents having sex when they get older, or, God forbid, in a nursing home that a couple should have sex. We have those community standards. And how they play out with men is that dirty old man syndrome. Men might think, oh, people will think that of me if I start talking about sex or whatever, okay? Now, yes, I do notice that, having worked with PCFA for a while, that I think your attitudes around sex are pretty different from the normal run-of-the-mill people. And you talk about sex far more openly, I think, than a lot of other people do. And I wanted to also say, as we go older, remember you're never too old to be in love. I took this photo on an Italian cruise ship. We went on a cruise last year in October. And this couple really impressed me. Every night they dressed up, they looked magnificent. They were the dirtiest dancers on the dance floor, I can tell you, of anyone, okay? They put young people to shame. They were enjoying themselves. They were just wonderful. I said a few words to them when we left about how wonderful they looked, and they were so much in love, and it just showed. And it was a real reminder that we, you know, the older we get, we can have a happy and satisfying love life and sex life. It doesn't have to stop. A few frequent backgrounds for sexual, what I'm calling sexual risk-taking for men, and by that I mean not using condoms to prevent sexually transmitted infections. Low or high self-esteem, confusion or anxiety about sexual orientation or identity, and if you are changing your identity, that's a high-risk place to be in. If you're trying something new or different, a lot of men get into sexual risk-taking. Travel, I think that's a big one. Men who travel to other countries where things could happen there that don't happen in Australia. Backpackers coming here to travel. We've set up a lot of STI campaigns aimed at backpackers. Alcohol and drug use, we know libido low or high, or the end of a relationship is often a time when we get into risky sex. Or end of a relationship caused through death. A partner suddenly dies and someone's grieving. One of the ways people grieve or think that they can cope with extreme grief is to go and have sex. It does happen. Okay, so it's another thing we've got to watch out for when people are grieving. In the UK, STIs are on the increase and have been for about 10 years in people over the age of 50, mainly because, I'll explain it, there's a lot of words up there that's a bit wordy, but it's about people who've been in relationships for 30 years or so and they've split up. And they've gone back into a single scene that didn't have a few bugs when no HIV didn't exist and didn't have the prevalence of STIs that are around 30 or 40 years ago. So we've had this major outbreak of people who have no idea about using condoms. And the same thing's happening in Australia, and we're not doing anything about it here. In the UK, they released this great safe sex campaign, and it was called To Stop the Middle-Age Spread of STIs. And it goes, remember wearing this, then remember to wear this, the little condom up there, right? And of course, none of you own up to wearing this. I know none of you actually wore these clothes, you know. It's some other people that we know that used to wear these clothes, right? But it's taking us back to that era and saying, remember to use a condom. We need these kind of programs in Australia, but we're not doing anything about it.
We need the hair to be like that.
Yes, and we probably do. Look, I'm not going to spend a long time with erectile dysfunction because I think your knowledge of it is really, really high, and you know what it is. It's primary, if it's happened a few times, or secondary, if there's a history of it happening. And we don't need to look at that. How common is it? 67% of men with any degree of erection difficulty consider it a problem, with 195 seeing it as a major problem. Again, that's figures from this survey of all men. So again, these are figures of, these are not men with prostate cancer. Main reason for seeking treatment, well, allows me to have sex was the obvious one. 54% though, important to my relationship. Then what do single men do? Question. Want to feel normal again, want to feel like a man again, important to general health and well-being. We're not sure that whether for single men some of those things also might be, you know, as important. There's physical causes that we know about, the side effects of prescribed drugs. Any guy over 40 who comes to me or would say, I'm having an erectile problem, first question is, do you smoke? And if they do, we stop them smoking. Guess what? Problem goes away. That's the first thing we'd look at. Then we do a lot of physical tests to see it's not something else, and then we'd look at psychological reasons behind it. Physical things would be all of this. Can cause erectile problems, as you're probably quite aware. And that's, yes, that's a proportion of erectile problems caused by other things. Diabetes is really high, and heart disease. But back to that slide, the orange segment up the top is all psychological and not physical. And we tend to forget this sometimes. Psychological reasons: anxiety, stress, depression, sexual identity, fear of contact about sex, pregnancy or fear of STIs, psychological trauma or abuse in your past, sexual problems with a partner, or communication problems. Can all be things that affect our erectile performance. Treatment, again an area that you'd know a fair bit about, the PDE5 inhibitors. Psychotherapy, talking to someone else about it, mechanical devices, implants, hormonal treatment, and intracardiovascular therapy, the injections. Of all of those things, I just wanted to mention one. Cialis once-a-day treatment, I think, is actually a bit of a magic drug in a way, for a few reasons. One, men can take it daily, and not with the other drugs. You have to actually plan to have, you know, your sex. I'm going to take the tablet at 6 o'clock, at 9:30. It's all going to happen. Mood lighting, champagne. Not everyone runs their life like that, and that's difficult, particularly single men. Okay, who never know when they're going to have sex, but the opportunity arises. If they're on 5 milligrams per day, they're fine. They can react to that. There's very few side effects, and it can be taken with or without food. And I don't know if you know, the new research that's only come out in the last few weeks in the United States, Cialis once a day is now prescribed for treatment for enlarged prostate, BPH, for that syndrome, to improve that. So there's another reason why it's a good idea, I think. Okay, I wanted to talk to you a little bit more. I'll just show some resources here you may or may not know of. Andrology Australia. Andrology Australia is men's sexual health and prostates. Women have gynecology, we have andrology. They have lots of free resources and a good website. Email I put out, and I'll send a copy to everyone here from tonight if I've got your email addresses. It's not if I send you a copy, you'll have a look at it. If you like it and you want to subscribe, you have to do that, otherwise you won't get another copy. So it's not spam mail. I wanted to give you a little bit of an update though on the Gay and Bisexual Prostate Cancer Initiative, just at the end here. This is funded, of course, by PCFA and supported by the AIDS Council of New South Wales, ACON, the Cancer Council of New South Wales, Victoria, and now South Australia, Victorian AIDS Council, La Trobe University, Monash, the Urology Society, and Male Care USA. It's been set up for gay and bisexual men who've been diagnosed with prostate cancer, undergoing treatment or survivors of, and their partners. We ran the first consultations to find out what their needs were in Sydney and Melbourne in August and October 2011, and that started support groups there. I'm the support group leader of the Sydney group, which is called Shine a Light. There's now support groups in Brisbane, and Adelaide is nearly up and running. Perth's scheduled to do in July, end of July, and then we move on to Hobart and Darwin. Why are we doing all this? Using the number of men dealing with prostate cancer and a really conservative estimate of the percentage of men in Australia at 5%. We can't get that figure right, but it's probably higher. But on that figure, 1,000 gay or bisexual men are diagnosed each year, and around 165 die each year from prostate cancer. That's what we know. So we need to change our information and support programs that we provide for men to take in different cultures and textures and varieties of men, to take in gay and bisexual men, to take in single men in their 40s who are developing prostate cancer earlier, to also look at Indigenous men and men from non-English speaking backgrounds, all of those groups. So that's why we're doing it. And a lot of men in this group aren't exclusively heterosexual. What's the difference? Here's some interesting results from the initial consultation in Sydney. A gay participant said, when my gay friends heard I had prostate cancer, they said, "You've got the big C," and most did not want to have anything to do with me after that, and all his friends just left. So the assumption that the gay community is in some way a caring and supportive community is a myth, really. It needs a big rethink. That's more than a myth than anything else. The second one is very interesting. A bisexual participant, my partner was in a heterosexual relationship, so I couldn't talk to him at all about how I felt or what was going on, and my family just said, "You'll get over it." So he had very little family support. My straight partner didn't understand how I felt and the changes I went through and how I looked afterwards. He just continued to want to have sex, and when I didn't want to have sex, and due to his lack of understanding my feelings, we split up. Now he has prostate cancer and he wants to talk about what he's going through. We're still friends and talk, but I was not supported by him when I needed his support. Entirely different perspective from the first one. So what's different? Sexual difficulties are different. Sexual difficulties are different from straight men, and erectile dysfunction issues with both regular and casual partners need to be addressed. Now, most of the men in all our support groups are single. I think generally most gay men are single and not in relationships, so that's a big difference for a start, because there often is not a partner around to support them. And often if they are in a long-standing relationship, they can both get prostate cancer. So they change from lover or friend to partner and back again twice in the one relationship, which is a big difference. They need specific information and support around the changing roles from partner to carer that I've talked about. There's a greater need for psychosocial support for gay and bisexual men, and some research from America has pointed that out, that they have higher levels of anxiety, depression and suicidality. We haven't done that research here in Australia, but we're on the verge of it. Health promotion resources, cancer prevention support program literature needs to address non-heterosexual men. And there needs to be more understanding about sexual roles and how prostate cancer affects sexual function for them. There's a great deal of homophobia in the community and medical teams, and this needs to be addressed through education and training. Gay men are often isolated from family and friends and have to deal with this on their own. Partners of men need a specific program, we've been told. 2 gay men, as I mentioned, can both get prostate cancer, and most are single and dealing with it alone. The American Cancer Program, Male Care, has been aware of the amount of single men in the United States dealing with cancer on their own, and they're about to launch a program called Going It Alone, which I think is a great move in the right direction for them, and we might have to think about that somewhere into the future. What we've done, we've completed a short review of Australian health education materials to see if any of them catered for men. None of them did. We've done that. Done the research, completed an online international survey about sexual flexibility and resilience, and we're analysing that. There's a pilot project using in-depth interviews with gay, straight partner and single men with PCFA has nearly finished its work. There's now a research project to consult with this group on what their health education materials are. That one has actually been completed. There's 2 new research projects funded by Movember, one in Western Sydney and the other in Melbourne. One looking at wellbeing and quality of life after prostate cancer for gay and bisexual men and their partners, and the other one looking at gay men and depression. And we've now got some trained PCFA ambassador speakers. I'm one of them. There's 3 in Sydney and 1 in Brisbane. And these you haven't seen yet because they're not available yet, but these are the new resources being manufactured for men with localised prostate cancer, advanced prostate cancer, younger men, and partners and carers of men, and gay and bisexual men, and these are the packages here. I've finished reviewing them. They're great. They're really well written. I've done a great job on these, and they're now going through the review process. We think they may be out September-ish, around about September maybe. And I just wanted to thank David and Pam and the whole PCFA team for all their support on this initiative and for their compassion in providing prostate care support to all Australian men, irregardless of their sexuality. I'm probably going to leave it there. Thanks.
Okay. Well done, Greg. Never disappoints. So we got some decent questions.
Or even indecent questions, I do answer them.
Yeah. Okay, great.
There was an ad on TV the other night, and I think it was for mentherapy.org.au.
Yeah.
And I read in a little note in the paper, and it said the man was supposed to be a rough and ready sort of guy. And I really didn't know whether it was a skit or it was a fair dinkum ad.
No, it's the real deal. It comes from America. The idea comes from America first. And what it really, we've taken it over to Australia. It's run by Beyond Blue. And the man therapy is this guy who's hard to describe, who's, he sort of looks like a English professor with the moustache and the golf clubs and this and that. He's a blokey bloke. The American one's an American blokey bloke, and we think this is the closest we could get to an Aussie blokey bloke. And if you watch the little, I don't know if did you watch the little YouTube thing on him?
No, I've seen it on TV.
Oh, okay. You can watch more stories as he talks, and there's also information on the website. It's largely about getting men to think about their health, and in a number of ways. Obviously about depression, that information's on the website, but other things too. Yeah, look, it's one approach. What I've always said to people is, how we improve men's health in this country, it's not a one-size-fits-all approach. That works for some men. Some men would look at that and go, I hate that, that's not me. You know, yeah, I don't get it. And other things we do for young men have the same effect. They go, no, don't understand that. So again, it's just something we're trying, that Beyond Blue's trying, and we'll see, it'll be really well evaluated by them, so we'll see if it works. But it's out there at the moment, yeah. Got launched in Men's Health Week.
Another question? Go on, Frank.
The booklet that you showed that you had written up the front, where's that available from?
Which booklet?
Your book. You said you wrote it.
My book. Okay. My book's available. The best place is from my website. If you go to the website, it'll direct you to how to get that. I've just changed publishers because you may or may not be aware, Millan Publishers has collapsed about a month ago, and they were my distributors. We've now got a different distributor, but we've got it there. You can still buy it, or you can talk to me about where to get it. I'll give you a card.
Good, thank you.
Yep.
Patrick, you want a question? Anyone? No, Greg, one of the things that I'm really pleased about, apart from all the progress we're making here, is that we are now starting to get the message out to support groups that we can talk in all these areas quite comfortably as straight people, just understanding the gay and bisexual situation. So that greater understanding is now starting to come. We've still got a way to go, but it's a hell of a lot better now than it was a couple of years ago.
Oh, yes.
And our literature now, there's no way in the world that you can look at one of our past resources and change it by putting partner instead of wife, and it just that language doesn't work. So now we've put a lot of effort into, with the help of the Cancer Australia grant, into making sure that our terminologies fit the great majority of people, which includes straight people and heterosexual people and gay and bisexual people.
PCFA did the absolutely correct thing by consulting with men in that group quite a lot about what they wanted in there, and they produced some great resources. This was the only one that was out prior to that, a few years old, from Westmead, about sexuality and cancer. I was actually part of I contributed stuff to this, but this is nowhere near what's needed. I think the PCFA resources are fantastic. They're really good, and I can't wait for them to be launched.
Are any of those books that you mentioned? Sorry, are any of those books that you mentioned right at the end, which you said are about to come out, are any of them available on electronic format so that people can actually download them as opposed
I imagine they will
having to
be.
order copies?
They will.
They probably will be.
When they're launched, they will.
Yeah,
Okay,
sure.
great.
Yeah.
Like all our publications, in the very immediate future, it'll all change and they're electronically accessible.
And I think the other point on that, David, when we did the focus group in Adelaide, it changed a bit. We had decided to open that up to a gay and bisexual men's health and wellbeing forum for men over 40. So there were 4 men there who'd had prostate cancer, another 5 or 6 who hadn't. And so what I did with that combination was I actually gave the new PCFA ambassador talk on prevention to them. And the evaluation report that we've got now, there were comments in there going, oh, didn't know anything about this, think I might go and get a test. Well, you know, when we get out into the gay community, the prevention thing's the next thing because they don't know a lot about it. And there were men there who could talk about it in the room, which was great, with other men who knew very little about it. So that's a good combination. I guess that's where we move next, past the support programs, is into the prevention area.
Yeah. And Greg, I should ask you to just touch on the challenge that we've got with medical professionals, because we've got quite a lot of medical professionals to get over the line to feel comfortable about talking to gay and bisexual men. It is ridiculous, but we do have this challenge, don't we, Greg?
Yeah, we do. I think from working in this area that, you know, it's pretty reasonable to say that most urologists don't tell their male patients anything about what's going to happen after treatment in terms of sexual function. Some do, some don't, but the majority don't. And in that whole group, we've got a whole lot of gay men who've gone, but I wasn't told this at the beginning. So we've got a whole lot of education to do with urologists, also with GPs, I think, but mainly with urologists. And I think we're starting to do that. We presented some things to the urology conference in Darwin. I think that's the way to go, that we keep pushing doctors, urologists, nurses, all of those people who are in the allied health team, and it runs over to them too. People, counsellors who are around supporting people. There's an amazing amount of ignorance there, you know. My little story is I ended up in the Mater a year ago for something that I didn't know was wrong with me, and I'm an ex-person who's had cancer. And I had pneumonia and that, and my partner was there, and this doctor came in and went, "Who are you?" And I said, "He's my partner." And he went, "Business partner? What partner?" It took him a full 4 or 5 minutes to get it. Meanwhile, both my partner and I were going, "Can we have another doctor? You know, like if he can't get this in 4 or 5 minutes." But that happens all the time, and it happens to gay men everywhere, particularly with any condition, but, you know, with prostate cancer, it happens all the time.
Mind you, this discussion about getting medical professionals to understand this subject more, I mean, heterosexual people are not left out with not knowing, because, you know, there's still too many doctors that can't talk about this subject.
Oh, yeah.
But it's... Now I ask the question, and we move in a lot of circles, it certainly is more predominant from our sort of understanding of the situation that the gay and the bisexual person has a much more difficulty in getting proper advice from medical professionals, which is really, as you put it, strange. Okay, one last question, or are we all overdone? All right, well, it remains for me to say thank you very much, Greg. We appreciate it, and so will everyone else.
Thanks for having me here. It's been a pleasure.